Would you say that India is also the capital of lung diseases, or do you think I'm just over exaggerating?
Because of our sheer population, we probably rank first or second in deaths due to asthma and COPD in the world. And that's actually scary when you look at it, but just because of our sheer numbers.
Now, vaping has become a cool thing amongst youngsters, air pollution. So it's only during these sort of episodes कि लोग को याद होता हो कि lungs are important. Would you sort of agree with this mentality, or do you think there's much more to it? What exactly do you mean by lung fibrosis? What exactly do you mean by this term end stage lung disease?
What's the end, right? I mean, I don't know what's the end for any patient, and I can't predict when the end is. Some patients whom you feel will last a few months, live for years. And some patients whom you feel will live for years get other problems and die of other issues much before their lung disease kills them.
What exactly do you mean by palliation? And correct me if I'm wrong. I thought palliation is only for lung cancer or any cancer. Am I wrong?
You're wrong. 5 to 7% of the population requiring palliative care come from the cancer population, and the other 92% come from non-cancer.
Does palliative care also support the caregivers, or
Yes.
are you concentrating only on the patient? Still, why do you think palliative care is so underutilized in India? हेलो एवरीवन एंड वेलकम टू DTalks विद डॉक्टर कपिल। आज का एपिसोड मेरे लिए बहुत ही स्पेशल है बिकॉज मुझे ऐसा लगता है कि एक पर्टिकुलर पार्ट है पल्मोनरी मेडिसिन के बारे में जो अनफॉर्चुनेटली हम ज़्यादा डिस्कस नहीं करते हैं, ज़्यादा प्रैक्टिस नहीं करते हैं, एंड वी डोंट इम्प्लीमेंट इट सो ऑफन, एंड दिस इज पैलिएटिव केयर in respiratory medicine. A lot of our patients are suffering from breathlessness, but are they really getting the correct care? Are they being directed towards the correct person? ये बहुत बड़ा question mark है, और आज के podcast में I want to answer this question. Got two wonderful guests for today's show. First is Dr. Sujeet Rajan sir. It's a privilege for me to in fact have him on my podcast. He's a consultant pulmonologist in Bombay Hospital. And we've got Dr. Leena Gangolli ma'am, who's a palliative care expert in Bhatia Hospital in Mumbai. इन दोनों के साथ बहुत सारे बातें करेंगे about how we can integrate the two, respiratory medicine and palliative care. Keep watching this episode on DTalks with Dr. Kapil. Hello everyone, welcome to DTalks with Dr. Kapil. Today we've got a very interesting topic. Interesting इसके लिए because it's a very underutilized topic, और वो है palliative care in respiratory diseases. Unfortunately, as a pulmonologist, मैं खुद आप लोग को बता रहा हूँ कि ये जो एक टॉपिक है, इट्स अ ग्रे एरिया, इतना ज़्यादा यूज नहीं हो रहा है. एंड आई हैव गॉट अ स्टेलर गेस्ट लाइनअप ओवर हियर. वन ऑफ माय आइडल्स एंड इंस्पिरेशन, डॉक्टर सुजीत राजन सर, who is of course a very very famous pulmonologist from Bombay Hospital, and of course Dr. Leena Gangolli ma'am, who is a palliative care expert. Thank you so much for removing time and coming on this podcast. Sujeet sir, I'll start with you. See, it's very commonly said that India is the diabetes capital of the world, the hypertension capital of the world. Would you say that India is also the capital of lung diseases, or do you think I'm just over exaggerating?
So, Kapil, lung diseases are very common. And because of our sheer population, we probably rank first or second in deaths due to asthma and COPD in the world. And that's actually scary when you look at it. But just because of our sheer numbers, we have a huge amount of burden of lung disease. So there's a lot of lung disease out there. And it was perceived as only tuberculosis 30 years ago when I started respiratory practice. But now we've realized there's so much non-TB lung disease that it's become quite interesting to practice chest medicine. And there are so many subspecialties now of chest medicine that a general pulmonologist, probably you have 6,000 in India, and there's still a shortage sometimes in some parts of the country. So we need more people in the branch. There's a lot of illness and there's a lot of mortality, but there's a lot of good work you can do in that space.
I'll tell you the funny thing in this, sir. Our population, unfortunately, remembers the lungs with, let's say there's a COVID. that's when the lungs shot to
Sure.
popularity. It's a very unfortunate thing because so many people died. Or let's say someone is discussing about smoking. Now, vaping has become a cool thing amongst youngsters, air pollution. So, it's only during these sort of episodes कि लोग को याद होता है, okay, lungs are important.
Sure.
Would you sort of agree with this mentality, or do you think there's much more to it?
So, COVID definitely helped us, especially a lot of inhaled steroid was used during COVID, and the taboo of using inhalers reduced there. There was a lot of spontaneous ask from the patient that I think I'll take an inhaler. And thankfully, many of them took it. Their coughs settled and they got better instead of unnecessarily using oral steroid. And we know what's happened out of oral steroid excesses in COVID. We have avascular necrosis of the femoral head and people having hip joints replaced today because of that. So COVID brought a lot of awareness in lung medicine, and I think that was good. But there's still a lot of work to be done. So it increased the awareness. Respiratory physicians became important players in the field of medicine in the eye of the average layperson. But I think the respiratory physician also needs to deliver. It's not enough to just have people say, oh, I have a lung issue. They need to spend time with the patient. They need to communicate well and get messages in lung disease across better.
Okay. So because you're talking about lung disease, there's a particular lung disease which I want to talk to you about, which is interstitial lung disease. See, the audience will probably understand this as lung fibrosis. The word fibrosis now has become so common, sometimes it's really shocking. Patients come to the clinic and they're like, sir, मुझे fibrosis हुआ है lungs का, मैं confident हूँ करके. So yes, the awareness is increasing, but what exactly do you mean by lung fibrosis?
Yeah, so it's one of the most fascinating parts of respiratory medicine and interesting parts, if you ask me, because that's an area I spend a lot of time in because it was like almost a death sentence when I was studying for my MD. And patients with lung fibrosis had few treatments. Everyone used to get, again, oral steroids and left to whatever. And as they got worse, given oxygen, no transplant availability, and they'd just be told this, you're just destined to, die in a few years. That has changed. Awareness has increased like anything. Again, post-COVID, because COVID caused interstitial lesions in the lung, but they got better, thankfully. But there are about over 200 types of interstitial lung diseases. When I mean interstitial, I mean the structure of the lung. So the airway is like a tree turned upside down. This is the trunk and the branches, right? And that's the simple part, Kapil, to manage. You take an inhaler for asthma and you're leading a normal life. You can participate in the Olympics. 15% of Olympic athletes are asthmatics.
Wow.
That common. And that normal a life you can lead. But the structure, which is like two big sponges around those airways, is the interstitium. That's the meat of the lung. And that transfers oxygen into our blood. So if that is affected, you have a bigger problem because the inhaler won't work, which is so safe to take, but you need tablets. And that's a disease where you're going to get breathless, you're going to cough, and you need to know whether that lining in the lung is more swollen or what we call inflamed, or is it scarred or fibrotic. And so you have then an interstitial lung disease or ILD. And as a chest physician, our job is to find out how much what's the diagnosis? Can you get the patient better with drugs? And if you can't get the patient better, can you at least stabilize the patient? And there, sometimes it's not only drugs, you need a lot of non-drug methods to stabilize the patient. So the conversations are fascinating. And there's much more you can do today than you could do 30 years ago. So ILD, patient, मेरे पास आता है and they come and say, ILD है. कौन सा ILD? And अगर ILD है तो reverse कर सकते हैं, stabilize कर सकते हैं, or do we have to just slow progression? This is the important conversation
Okay.
to have with the patient.
Okay. So there's a very interesting terminology आजकल. You mentioned about ILD and आपने mention किया कि there are, let's say, कुछ है जो stabilize हो जाता है, कुछ है जो reverse हो जाता है. But see, there's this term which is known as end stage lung disease. Sometimes that is not, patients are not labeled as end stage lung disease, but amongst physicians, what exactly do you mean by this term end stage lung disease?
Yeah. I don't like the term, Kapil. It sort of makes the patient feel they're at the end, and किसी को अच्छा नहीं लगता है जब बोलते हैं कि end stage lung disease.
Correct.
No one likes that,
Correct.
So I think the better thing to say is advanced lung disease or lung disease जो काफ़ी severe हो गया और हमको अभी reverse करने को सोचना चाहिए या can we improve it?
Correct.
And end stage, when you say end stage lung disease, you don't know what's the end, right? I mean, I don't know what's the end for any patient. And I can't predict when the end is. Some patients whom you feel will last a few months, live for years. And some patients whom you feel will live for years get other problems and die of other issues much before their lung disease kills them. So I don't think it's fair. Even end-stage kidney disease is a terrible way to refer to a patient. I think patient को ऐसा लगता है कि this is the end. So I prefer to use chronic, and we are trying to develop a subspecialty in chest medicine, which will be ILD and chronic respiratory failure. And that means you have a chronic problem. Now deal with it. Now we will help you deal with it. And most of our diseases are quite chronic. You have to deal with them. Some of them allow you to lead a perfectly normal life. Some of them a slightly compromised life. What's the problem,
Correct.
But end stage is a little worrying.
Wonderfully put, in fact. I think if a patient is watching this, they'll appreciate this, but because I mentioned this is a ekdam gray zone jaisa, we never mention this to the patient, but that's what we very talk colloquially, amongst each other and amongst colleagues, that it's an end stage lung disease or something. And yes, right, like you mentioned, patients dar jate, they're like literally scared that it's an end stage, thing. Leena ma'am, you've been listening very patiently to, Sujeet sir answering, and in between he did mention that sometimes there are non-medical things which, we might attempt or we might do for patients. Ma'am, you're a palliative care expert. Firstly, what exactly do you mean by palliation? And correct me if I'm wrong. I thought palliation is only for lung cancer or any cancer. Am I wrong?
You're wrong.
I'm wrong. Okay.
So palliative care, we also call it supportive care and comfort care, because the word palliative care has historically been associated with cancer. And that's because it took its roots in cancer. So, when it was started, Dame Cicely Saunders in the UK, it was started as a care offered to people with advanced cancer who had no curative options. And so therefore this was offered as symptomatic and psychological support. So symptomatic treatment, so treatment to address the distressing symptoms, physical symptoms like pain, breathlessness, nausea, vomiting, diarrhea, constipation, anxiety, depression, right? And also the psychological aspects. But over time, we've realized that only 5 to 7% of the population requiring palliative care come from the cancer population, and the other 92% come from non-cancer.
Wow.
And that 92% includes respiratory conditions, neurological conditions, advanced kidney disease, advanced liver disease, the entire geriatric group. So Alzheimer's, dementia, Parkinson's, etc. Okay? So what is palliative care? It's care which is offered to any serious life-limiting condition. Okay? When we say life-limiting, we mean limiting either the duration of life or the quality of life. Okay? And it's offered to address distressing symptoms. It's offered to both the patient and the family members or the people who love that patient. And it is offered ideally from early on in the diagnosis right through the trajectory of the illness to a very advanced stage where we would offer what's often misunderstood as palliative care as end-of-life care. You are going to come to that.
I was about to ask you that.
And of course, we continue with bereavement support or grief support for the loved ones of the patient well after the death of the patient. So that is what palliative care is. It's a continuous kind of
Because
continuum
this
of
is a
care.
very common misconception, There are a lot of people who think that palliative care is the same as end of life care. Sometimes even the word palliation, when you mention it to patients, I'm sure it will be perceived negatively.
Yes.
यार ये doctor क्या बोल रही है? ऐसा कैसा हो गया? Is this terminal? That's the whole concept. You did touch upon this, ma'am. Then what exactly would you say is end of life care? And how is that different from palliation?
So when we start, if we were to look at a kind of graph of palliative care, and if we were to start early in the diagnosis, at that time we will focus on maximizing the independence and functionality of that patient. So let me give you a concrete example. Let's take something in respiratory medicine, right?
Okay.
A patient is diagnosed with interstitial lung disease. So we want to now maximize how long that patient will be able to stay independent and stay functionally fit. Okay, so we would start, as Dr. Rajan said, we have non-pharmacological measures too. So we will start with respiratory rehab. So, a strong physiotherapy, strong respiratory physiotherapy. We want them to be able to, breathe and maximize their lung function. Also maximize the energy they have in the day, because with lung, with as what's called fibrosis, there's increased work of breathing, and so therefore there's more fatigue. And so just how to plan their day, how to conserve their energy. So this is something that the team would work with. And one thing I'll add here is that palliative care is also a multidisciplinary team approach.
Okay.
So there's a physician, there's physiotherapists, there's nurses, counselors, social workers, speech therapists, speech and swallow therapists. It's multidisciplinary. And so to answer your question, we would start with trying to maximize functionality. And over time, we expect that there will be a decline. And the patient will move to a space where they become less independent. Then they'll move to a space where they're completely dependent and where some of our medicines are not working anymore. There are exacerbations happening in this patient, so they're having repeated pneumonias, repeated hospitalizations. Function is declined to a point where they're now dependent. And their vital statistics, or like their blood pressure, saturation, etc., starts becoming an issue. That is when we may consider offering what's called, again, I'm very, like the way Dr. Rajan said he's not comfortable with the word end stage, I'm also not comfortable with the word end of life care, right? Because what I also feel is it's not for us to really decide who's end of life and, who has days or weeks, etc. I prefer hospice care, the word hospice or hospice, because that is where we discontinue medications which are no longer giving any benefit, and we would only work with comfort care for that patient. So the difference, if I had to give you a basic difference, with palliative care, we offer all of these supports alongside the disease-modifying therapy. So for example, if the patient is receiving antifibrotics or they're receiving something, this care is given alongside that.
Got it. So nothing is stopped basically.
Nothing is stopped.
Medications are always
yes.
continued.
But at what we call hospice care, we might actually start deprescribing some of these medicines because we don't feel they're doing any good for the patient, and then we will concentrate on comfort care.
But ma'am, first of all, I'm very shocked with the statistic which you gave. 92% of the patients which you mentioned refer to palliation actually non-cancer.
Yes.
So a big myth is busted, that it's only cancer which is the same as palliation, that is busted. Now, city like Mumbai, we've got, let's say, 2.5, 2.6 crore people. How many palliative care experts are there?
So Mumbai is actually doing pretty well.
Really? Wow.
In the sense, we have palliative. We have a palliative care consultant in at least 5 or 6 hospitals in Mumbai. Wow. We have a couple of community-based organizations that are offering palliative care. So a lot of us are supported by CSR, by Corporate Social Responsibility, one of our largest supporters being Cipla Foundation.
Okay.
And so we have partners across Mumbai. We also have an informal network of palliative care providers called the Mumbai Palliative Care Network.
Wow.
And we are a network of providers both from private hospitals and community-based organizations. And, suppose, for example, I have a patient in Ulhasnagar and I need to make sure that there's continuity of care for that patient. I can put a request on our group, and by evening, I have someone, to hand over care to in Ulhasnagar. So Mumbai is pretty well. I would say Mumbai is pretty
good
well.
news for Mumbaikars.
Yeah.
That's good news.
If I can jump in
Yeah.
here, 5 or 6 hospitals out of.
Oh yes, out of many, many hospitals. Yeah. So
But then
It's
still
still
doing
there.
quite
It's
better.
still
I mean,
better than many other cities.
yes,
I agree,
it's
but
better than other
It
cities.
should
yeah.
be much more.
So
in
it's
my
not
view.
zero, but yeah,
But then you know what? Sometimes when, let's say there is a patient who's unfortunately suffering from, okay, I won't use the word end stage, sir doesn't like it, but let's say chronic disease, okay? We sometimes underestimate the suffering, the anguish which the caregiver goes through. Sometimes they have to sacrifice so much, their job, their time, everything. Does palliative care also support the caregivers, or
Yes.
are you concentrating only on the patient?
No, so by definition, palliative care, the unit of care, is always the patient plus the family or the loved ones of that patient, which include not only the caregiver but the family as well. So, for example, if you have a young male, for example, you're supporting his wife, but you also have to support the children,
Correct.
right? Because there's going to be a lot of psychological burden on the family. You have to have there's a lot of psychological distress. And so part of every palliative care consult is not only the patient, but also the family caregiver.
That's so good
We
to hear.
have tools to measure distress, and we often have to say to family members that, there's something called caregiver burden or caregiver burnout, and this is a real thing. It's not and it's such a relief for family members when they hear that if they're feeling stressed or burnt out, they're not bad. It's because they're human. They have only so much psychological reserve. They're often taking care of a sick loved one. They're also running the rest of the household. There's so many things to do. It's okay if they sometimes feel burnt out. And they just need someone to tell them that. And then it opens up. They'll tell you that, I am burning out. I've just had enough of this or whatever. I mean, they'll tell you that they're having difficulty coping. And that's where we can have our multidisciplinary team approach. So we can have a psychologist work with them. Sometimes one of us just directly works with them. But caregiver burden is real.
But which is so good to hear, the fact that, you also pay attention as a branch on the family members, because sometimes that's something which we don't discuss very often. Unfortunately, I believe that as doctors, we are so focused sometimes only on the patient that a lot of the periphery stuff we sometimes miss out.
Yes.
At least I do. But it's so good to hear that, this approach is being used by your entire team. Sir, I just want to ask you this question. So, she did mention that palliation is like a huge continuity of care right from the beginning, look after so many things, multidisciplinary team. Let's say today there is a patient who comes to you, 60-year-old. You have diagnosed this patient as lung fibrosis.
Sure.
Let us not discuss about the types and all, but there is basically a lung fibrosis. When exactly would you like Dr. Leena ma'am's input in the care of this patient? Is it right at the beginning, or would you wait for some time?
So, if you ask me, in an ideal world, I would like it on day one for any chronic disease. I would want everyone to think that there's more than a specialist can do in conventional medicine. Like, you meet your pulmonologist, you meet your cardiologist, you meet your neurologist, but Kapil, you never meet someone who's seeing you with a little different set of eyes. And that's what one of my mentors taught me, that there's no huge skill set here, but just look at the patient differently. The patient's walked into my room with a lung disease, but his problem is he just can't walk steadily. And his only problem is that I want to walk without support. And I am so obsessed with his lung disease because I'm trained in respiratory medicine. I'm saying, oh, you got tuberculosis, you got an ILD there, and you got chronic kidney disease. But at the end of half an hour, he's saying, how can I walk without support? And, if you miss that, Kapil, you've missed everything the patient came for. And that's what I realized with palliative medicine, that you need to focus on what the patient's priorities are as well. I mean, yes, you will treat the lung problem, but also see why the patient walked into your room. And have you even addressed that properly? That's where it's so important that, and I would call the palliative specialist really a quality of life specialist. How are you and a quality of life specialist like Leena going to co-manage the patient? And so if everyone and every second patient of mine, Kapil, is either stressed or anxious or just doesn't want to hear the diagnosis, is worried about the treatment, and is worried about the prognosis. Who's addressing that, Kapil? No one. We just feel so good when we have made a diagnosis and we've put the patient on treatment, or someone's gone and told the patient you have 3 years to live or 2 more years to live. Who's dealing with the patient's emotions? The caregiver's emotions. And sometimes the patient, yesterday I saw a patient who said, look, I'm 85, I'm doing fine. And his daughter stepped out of the room for a phone call. And he said, look, you need to handle her, not me. Who's going to handle that? So I've asked them to meet Leena now, because Leena will focus on the daughter as much, if not more, than the patient. Because she is just, her priority is, my dad is like this trophy that has to keep living. Someone's told him 90, 100. And she has so much more to cope with than the father who's just chilling out on a chair saying, Doc, I'm fine, actually. Just deal with her, You get what I mean. Right? And that's what we often miss. And I think pulmonologists, who are all dear friends of mine, and me included, when I started my practice, I wanted to vomit out all that I had learned in my MD without realizing that the patient had come for a different reason altogether to see me. So we need to just ask and say, why are you here? Sometimes they've met 5 chest physicians and ask them, look, out of these 5, 3 are very good friends, outstanding pulmonologists. Why are you here? So we haven't understood what we have. Or we don't know where this is heading, or have side effects, and no one spent that time. So time is such a critical thing here. And the average time of a GP consult, in my view, in India is less than 5 minutes. And the average time in a specialist consult, if the patient is lucky, is 15 to 20 minutes. And this is what I've heard by word of mouth. I don't have data on this, but I would think some people would even be happy if they got 20 minutes, And how are you going to address some of these issues,
I think, sir, 20 minutes, like you mentioned, is a luxury. In fact, that's what I feel, because the OPDs are so full.
Absolutely.
But these are golden words, actually, sir, which you mentioned, because very often we miss that one thing which actually the patient wants addressed. We are so focused on what we want to diagnose and all of that. We completely skip this.
Sure.
But these are golden words, actually mentioned by sir. I hope young doctors are taking note about this. Ma'am, see, one of the main things in respiratory medicine, all our patients are breathless. Can be subjective. It's objective also, but breathlessness as a symptom is really worrying, because see, a patient's breathing every single second, right? So sometimes when a person is having, let's say, a lung pathology, he's aware of that every second of his existence. Something's not right, something's going wrong, it's anxious, it's stressed. So how do you, from a very palliative perspective, view breathlessness?
So from a palliative perspective, I view it as it's a very distressing symptom, and it's up there with pain. So, usually in palliative care, the first 2 things we rule out and address are pain and breathlessness, because those are the 2 most distressing. And so we use, as I said, non-pharmacological, but we also use pharmacological methods. So we use simpler things like, switching a fan on and having the fan blowing in the face, or opening the windows, allowing fresh air movement. But then sometimes we do need to use medications. We do need to use anxiolytics, so medicines to reduce the stress and anxiety, because we do recognize that there is a psychological component to breathlessness as well as the actual physical component. And it becomes a cycle. So the more anxious the patient becomes, the more breathless they become. The more breathless they become, the more anxious they become. And we need to sometimes give a medicine to address the anxiety, to reduce that, to break that cycle. And there's now a lot of evidence suggesting that a very small dose of opioids also helps with breathlessness, what we call refractory breathlessness. So breathlessness that is not responding to any other treatment interventions. We can use a low dose of, and this is something where, again, there's a lot of perception to be handled, because some people are very frightened when they're told that we might need to consider morphine. Because again, morphine is associated with cancer. People associate it with addiction. There's a lot of negative beliefs about morphine. So we need to sometimes, so part of palliative care is also conversations. It's very difficult conversations and understanding what the patient's goals of care are and what we can do to address those goals. But yeah, for breathlessness, we sometimes have to use medicines.
It all boils down to what you mentioned, conversations. You
Yes.
know, what even sir was getting at. You know, sometimes 5 minutes, GP, it's just not possible. You need to spend more time with patients, even from a palliation perspective, and even from, let's say, a specialist approach.
Yes.
You want to say something?
Also, following on what Leena said, I have stopped teaching my postgraduates to take a history of grade of breathlessness. That's what we are taught, grade 1, grade 2, grade 3. And then we did a study that showed that 40% of Indians are suffering from some degree of breathlessness. And
Me
of that,
included. I'll include myself.
And many of them don't even go to the healthcare facility. So the changed question I tell my postgraduates, ask the patient, what has he stopped doing that he was doing before? And you will get much more insight into what the patient is suffering from than just saying, okay, can you walk till the bus stop, or can you walk to which are things they don't even want to do sometimes, or it's not part of their life. So how has that symptom impacted your life? And then you will know what you can try to help them with. So change the question.
Yes.
Wow, good approach.
Yeah.
That's a lovely approach.
And
So, but let's say,
and I just want to add, and sometimes it also just helps to ask, what could we do right now that'll make you happy or that'll make you feel better? And you get the most interesting answers. I remember we once had a very advanced respiratory condition, and he said, I want to go on a holiday. He knew he didn't have much time. He said, I want to go on a holiday. I want to stay in a bungalow in Mathiran. I still remember. And we were just worried that the altitude would cause a flare-up for him. So we had a discussion with his daughters, and we decided that Alibag was safer because it was sea level.
at sea level, yeah.
So we said, how about Alibag? The daughters found a beautiful rental bungalow, and they drove to Alibag with him with portable oxygen, with a concentrator, with rescue medicines, everything. They had a nice weekend there. They sent photographs of all of them in Alibag. He came back, and then a little later, he did pass on, but the family was happy that they had that holiday. Sure. And so it was more than just the illness. It was what will give joy. And we kind of went after that in the little time that we had.
If I could pitch in something, just as an extension of what ma'am was saying. So sometimes in transplant, that's what we do. We ask the patient that if you do have a successful transplant, what do you want to do? And like you mentioned, you get really fascinating answers. Something so trivial as riding a horse, which, we're just like, okay, there's nothing great in this. But for that person, it means a lot. Mm-hmm. These trips with families and all, we get that answer so often.
Yes.
I just want to do this. I think the Japanese call it ikigai. Have a purpose. You need that purpose in life.
Yeah.
So that's what we are trying to work on, and try to elicit this history from patients. But, sir, I wanted to ask you, when you do refer your patient to her, let's say,
right,
what do you do about the baseline medications which the patient are on? Do you want to have control over the patient taking it? Do you let her take control? How does that work?
First of all, I think patients are getting far too many drugs these days for whatever reasons. Let's not even get into that. But what I've learned from palliative medicine specialists and geriatric specialists, I attended a geriatric OPD when I was in UK, and I just sat in the clinic for a few consults, and I realized 90% of the time the consultant was just striking off drugs. Take out your drugs, let me see your drugs, this needs to go, that needs to go. So I said, that's the one thing I learned sitting, watching you see elderly patients, was just taking off drugs. He said, yes, because that's what's causing a lot of their problems. So with no disrespect to pharmacology, we have a great pharmaceutical industry, we have the best prices in the world, and we have access to medicines, but we also got to be careful and responsible when you prescribe them. So I think one of the things when I see this patient is, and when I refer to Leena, is how can the drugs which need to stop, I think I have a reasonable idea, but the drugs which are really going to help, there may be small changes that she can make that can make such a huge difference to their quality of life that we have not even been trained on that, Kapil. It's not because it's not a department in the medical colleges. So when Leena says 5 to 6 hospitals in Mumbai, I'm delighted because, we've made some headway. But every hospital should have it. Every hospital. I mean, why are you not focused? We are dealing with health, right? So why are we not focused on quality of life? If we are just dealing with disease, then you might as well put every disease into an AI algorithm and get your protocol. And that would be the end of the story. AI can never replace conversations, human connections. And I think that's why we're here.
I hope patients do understand the last thing that he's saying, because previously it used to be Dr. Google, now it's Dr. AI. So now patients are also using ChatGPT for a lot of stuff.
Sure. That's good. I mean, it is helping us. But we need to know what its limitations also are, is what is fed into it, right? And every single conversation you have is unique with a patient. And that's what I enjoy about medicine more than anything else. And every single conversation is never captured by a database.
True. But then, he did mention about this part, ma'am, and you had spoken about this, there are, let's say, 4 or 5 hospitals in Mumbai. Mm-hmm. But still, why do you think palliative care is so underutilized in India? Like he mentioned, it should be there in every hospital. It's still there in, let's say, 3 to 5. Why is it so underutilized?
I think part of it is just the perception about what it is. People, if you start with just our medical education, the way we were trained as doctors was generally with a curative intent.
Yes.
We were taught to cure, right?
We thought, sorry to interrupt you, and we thought we had failed if the patient died.
I mean, it was just that perception that if you can't do any more for the patient, then somewhere you failed, right? So the first step would probably be to integrate palliative care training into the medical curriculum, which is, of course, being worked on now.
Correct.
And then, of course, the perception of many consultants who are, of course, well-meaning, but they feel that they're in charge of their patient's care, and to hand over to another doctor is difficult. And it's not just, there's lots of studies about this. It's not just finance. It's not just that sense of ownership or whatever you want to call it. It's just that it's a well-meaning thing that I want to take care of my patient and I'm not comfortable handing over to another doctor. So what is important to understand is that palliative care, we believe in integration. So we will continue to work with the consultant. We will still take feedback, but we just give that added support to the patients. And this is something I've noticed. So amongst the facilities available in Bombay, there's also now an inpatient facility specifically for palliative care called Sukun Nilaya Palliative Care. It's supported by Cipla Foundation. And it's a charitable organization, so it's a free service of inpatient care for non-cancer palliative care. And even there, we had to do a lot of groundwork with physicians so they would understand that a referral to a palliative care center can include rehabilitation. So we have neurological cases staying with us, and we have a neuro rehab center, and we actually have patients with stroke coming in and actually improving with us and leaving. So it's also a perception that palliative care does not mean a downhill progression. Palliative care can be support. It can actually be a little bit of recovery and rehab. So I think that perception needs to be changed with physicians, and that would probably help. And this is with all of the systems actually. So neurology, respiratory. There can be some improvement if palliation is started early.
So she spoke about integration in the end. You mentioned different
Integration,
subjects and all of that. But I want to talk, let's say, only about pulmonary medicine. Let's say.
Right.
Do you think practically and on ground perception of, let's say, integration of pulmonary medicine and palliative care? First of all, do you think it's possible? Second, if yes, how would you look at it?
So it's only possible when chest physicians understand the value of a palliative care physician involved in the care of a patient. If that doesn't change, the chest physician will still perceive, and I'm talking about specialists and super specialists, will still perceive that the role of a palliative medicine specialist is for end-of-life care. And that is what needs to change. And it's not going to happen overnight. But I think if your audience tuning in realizes that there's more to healthcare than just a diagnosis or a label and a drug. Patients want to live better lives, they want to lead fuller lives, they want to do more things, and they want a happier family environment as well. Is their specialist able to address all this? 90% cannot, I can tell you. And the moment we integrate it, and Sonia Danoff told me this from Johns Hopkins when she visited India, and she said all her patients go to the palliative medicine department with ILD, and she said it's just integrated, right? And it will happen because right now the situation is, Kapil, if I sometimes tell my cardiologist to involve a palliative medicine specialist in a patient with advanced heart failure, very old, lung disease, his question to me is, are you giving up, Sujeet? And I don't know how to respond to that. And I got to tell him, I have given up on a cure for this lady, but I will never give up on her care. And if you understand what palliative medicine it is, how do you care for a patient to make them feel better? And so he said, what do you mean? I said, meaning she wants to get out of the ICU. She wants anything but not in the ICU. And so that we haven't even addressed that issue of this poor lady. Instead, we are trying to give her one drug after another, keep her in a cold environment, away from her family. What have you achieved? So it made him reflect that time. And now he's referring. Now he's understanding the value of palliative medicine. But it's a slow change. And the only way it'll come is if the medical fraternity also thinks about it that way. And then the patients say, hey, that was a doctor who spent some time with me and who actually talked to us about issues we are facing on a day-to-day basis, rather than just looked at our CT scan and, which is important. But they addressed issues which no one listened to us this much. I remember the home palliative care team that Leena talked about. They came back and said, superb, Dr. Rajan. Thank you so much for getting this home team to come. And I said, what was the most important thing, take home from that home team? They just listened. They just kept listening. And we were telling us all, no one ever listened to us for half an hour on what our healthcare issues were. And you just get emotional when you hear this stuff,
But that reflects sometimes so poorly on healthcare,
Yes.
The very fact that some relatives are actually saying that no one listened to us.
Right.
It reflects very poorly, I feel, on the healthcare system and the time that, each one of us spends. Absolutely. I hope this podcast also helps in, people perception about palliative care medicine. Let's hope.
Mm-hmm.
It comes with small instances, Kapil, So because we have Leena at Bhatia Hospital, the nurses, and we had Rajam before her, the nurses, the resident doctors, they've all realized the value. Because finally, who's with the patient the whole day? The nurse and the RMO in the ICU. And they see these consultants, me included, who come in for not as much time as the patient wants and leave. And then they see someone who's actually looking at, are you turning the patient? What's the bed sore looking like? This patient looks angry, upset. Have we addressed that? The relative is falling ill, looks like the relative or the caregiver hasn't slept the last 3 days. Who's addressing all this? Then they realize the value, because patient satisfaction goes up. Goodwill of the hospital just goes up like anything. But because we have so few, that's the big change that needs to happen.
So I'll ask each one of you one question. According to you, as far as, let's say, palliative care in chronic respiratory diseases are concerned, what is the one thing which each of you feel is ailing the healthcare system? Just one thing.
I think it is integration of palliative medicine in mainstream medicine. This is one thing, and I know, and people often look at me and say, oh, you're so obsessed about palliative medicine, Sujeet. It's not obsession. It's just that, don't even call it palliative medicine. Just see what the specialist is doing. If that can be done, and one pulmonologist told me, oh, we are all palliative care specialists as doctors. I said, I wish. I said, if we were all palliative medicine specialists, we would be spending double the time on everything we do with our patients, which we aren't. So we need integration. And so if there's one thing I would say is that hospitals realize this is important for healthcare. Then whether it's private equity funding a hospital, a corporate hospital as they're called, or a hospital with pressure on its bottom line, everything will fall in place, because all that is also required as we grow as a country, as our hospitals mushrooming. But we also need good healthcare, not just medical care. And so I always tell people who ask me about this, we need to move from medical care to actual good healthcare.
And ma'am, what do you think?
So I think we need to empower our patients and their family members better. I think what happens is, most of the time when I meet them, they're very confused, they're very frightened, and they feel very disempowered. And so, just teaching them, letting them understand what they actually have, what it looks like going ahead, and how the family members can actually be actively involved in care is something which I think is very empowering, and I think that would help.
And there's one aspect, I just wanted to ask you about is, are there any financial burden on the family and, let's say, the patient and everything when they are referred to a palliative service?
So we understand, so one of the concepts in palliative care is the financial pain or the financial stress, because any long-standing condition has been a financial burden to a family. But having said that, there are a lot of facilities available, both in the private sector and in the charitable sector, supported by corporate social responsibility. So Cipla Foundation supports about 38 to 40 projects across India.
Wow.
And they also run a national toll-free helpline called Saath Saath, which runs, we can give the timings and the number, and anyone who calls that number is connected to a palliative care center across India, which either meets their needs based on the patient's condition or the geographic location of the patient. So for example, we could be taking a call from another city for a patient whose needs might match what we can offer as a center. So that's the Saath Saath line.
Okay.
And the Maharashtra government, about a week ago, they have issued a GR where they have announced that they'll be strengthening palliative care services through the government hospitals, through the National Program for Palliative Health Care. So palliative care is hopefully going to become more affordable and accessible to everyone.
That's a step taken by the government of Maharashtra. Hope the other states also do follow.
Yeah.
I get your point, Kapil. Patients don't want to visit multiple specialists. And the moment they hear of palliative medicine, they think, oh my goodness, another consult, another fee to pay. And I think this makes people wonder whether all this service is going to be more expensive for them. And in India, that's a real issue. And that's why I say integration is so important. That means if a quadriplegic has to meet a neurologist, it is non-negotiable. You have to meet the palliative medicine specialist as well, right? The patient doesn't leave the hospital without that conversation as well. That is called integration. It's like we thought about in the ICU, when I told my medical director once, we need a psychologist. We didn't even have a psychologist at one of the hospitals I work. And you know what his response to me was? We have 8 ICUs. We need one at each ICU. I said, you don't even have one. Forget about 8. What he meant is every day he was getting complaints from patients or from doctors that patients are angry, they're upset, they're grieving. So you have to integrate. So I think in Bangalore, a hospital had started a grief counselor. That means everyone in the hospital, every patient in the hospital in the ICU, there'd be relatives outside. This counselor would just be moving around. So that's what integration is all about. Otherwise, you don't want another healthcare service, in inverted commas, which is draining the patient's pocket. So you want better healthcare. Patients are ready to pay if they see value in that time, but they don't want it as a repeated service that they have to keep paying for. So how can you integrate it? So they say, okay, I met the neurologist, I met the chest physician, and someone told me how to cope with this better. And that was like in a package, and I didn't even know. So this is what the hospital offered. That's how the hospital needs to work on it. Okay. That's what Leena and I are trying to work on at Bhatia, where almost every patient with chronic disease should be integrated into such an ecosystem.
Okay. So before I wrap up the podcast, my final question to you is, let's say there's a family who's watching this podcast. Unfortunately, one of the family members is suffering from interstitial lung disease. What is the one thing which you would want them to change about themselves, which will help in their lung journey?
So again, I'd come back to empowerment. I'd like them to change the feeling of helplessness that they have, maybe reaching out to a palliative care team to address their fears, their distress, and try to feel a little less helpless and look for 1 or 2 things per day that make them happy and joyful.
So integration and empowerment. I think we'll wrap up this podcast on that. Thank you so much, Dr. Sujeet Rajan, sir.
Pleasure.
Thank you so much, Dr. Leena Gangolli, ma'am, for sparing time out. And I hope that there is more integration and there is more empowerment. Thank you so much. Wow. Too much. सच्ची में ये इन्फॉर्मेशन एक्चुअली बहुत ज़्यादा ज़रूरी था, एंड इनफैक्ट नॉट ओनली फ्रॉम अ पेशेंट्स पर्सपेक्टिव बट इवन फ्रॉम अ डॉक्टर्स पर्सपेक्टिव. इट वाज लाइक it's like I have returned back to school learning so many important things. You especially heard those 2 important words, integration and empowerment, और ये somehow मेरे मन में एक imprint छोड़ दिया है. हाँ, we need to spend a lot more time with our patients is something which all doctors unfortunately are guilty of. But कहाँ ना कहाँ ये छोटा सा change अगर हम कर देंगे, believe me, it's going to be much, much, much better from a patient care perspective. और जैसे सुजीत राजन सर ने बताया, there is a difference between care and cure. Hopefully this podcast will help a lot of people who are suffering from respiratory diseases and even non-respiratory diseases, because palliative care जो है ये सब पे काम करता है, सिर्फ कैंसर पे नहीं. जैसे मैम ने बताया 92% is to 8% ये रेशियो है. So please, if you do feel anxious, if you feel lost, if you feel कि आपको कोई सही तरीका मिल नहीं रहा है, we've also displayed the helpline number. आप कभी भी कॉल कर सकते हो, and our aim is to deliver palliative care no matter where you're from in India. Hope you guys enjoyed this episode. Keep sharing, keep liking, keep subscribing. DTalks with Dr. Kapil.